total increase of 51%. And just in North America alone, the number is 48, and that is going to go up to 63 million in the next 25 years. And that is a total of 33% increase. But our counterpart, Europe, is doing better in that aspect, as the number is just going to go up to 15%. But if you look at the other parts like Africa, Middle East, the number is going to go up exponentially. So who is at risk of diabetes and whom do we screen? Mostly the patients who are 45 years or older, or anyone with less decreased physical activity, anyone with a history of family history of type 2 diabetes, blood pressure, gestational diabetes, or overweight, or with BMI of more than 25. And some of the ethnic groups like African Americans, Hispanic, Latino Americans, American Indians, and Pacific Islanders, and some Asian Americans are also at higher risk of developing diabetes. So how do we diagnose the diabetes? It is through the A1C or the fasting blood sugars. So when we consider the A1C, we want the A1C to be less than 5.7. That is normal. So any A1C between 5.7 to 6.4, we consider that as prediabetes. Anything above 6.5, we consider that as diabetes. And in the same way with the fasting blood sugars, if the fasting blood sugar is 99 or below that, it is normal. Anything between 100 to 125, we call that as prediabetes. Anything above 126, that is the diabetes. So once a patient is diabetic or a pre-diabetic, we always emphasize on lifestyle modifications. So what are lifestyle modifications? That is what we eat, what we do, and how we lower the weight. And coming to the nutrition part, the key ingredient is the carbohydrate. And what are carbohydrates? That's the starches, sugar, and the fibers that we eat. And whenever we serve anything in our plate, make sure that half the portion of the plate is mainly filled with non-starchy vegetables, which could be like lettuce, salads, tomatoes. And the remaining half, again, we divide into two halves. And the 1/4 half, that is the protein part, and the rest remaining, we can fill it with the carbohydrate. And it is also important to read the food labels and counting carbohydrates and getting into a habit of, planning the meals. That helps with the time and also with our health. And the next key component is the physical activity. So ADA recommends of being active at least 150 minutes per week. That is a moderate intensity exercise. So whenever you're at home, try to do some home chores or, like mowing the lawn. Or if you're at work, try to move more frequently, going up the stairs or down the stairs. And if you don't want to do any physical activity or cannot do, then try to get into some activity like, playing a sport or, picking a hobby that involves a little bit of physical activity. And what are the blood sugar goals? So normally for a fasting or a pre-meal blood sugars, we want the blood sugars to be between 80 to 130. And 2 hours post-meal, we want the blood sugars to be less than 180. And when we say an A1C of 7%, that means the average blood sugar is around 154. That is the median blood sugars. And some of the patients don't like to check the blood sugars. And for them, we have the newer technology, which is the continuous glucose monitoring. So these are the little sensors that you can put it on the upper arm or on the abdomen. And you can start checking the blood sugars every 5 minutes. And you can change these sensors every 10 to 14 days based on what kind of glucose monitoring system that you're using. And we often get this question like, what is my goal A1C? And the A1C goal is different from patient to patient, and not two patients have the same A1C. For example, a normal patient, we want the A1C to be like less than 7%. But if the patient is a little old or has other chronic medical conditions, then we want the A1C to be closer to 8%. The main goal here is to decrease the hypoglycemic episodes. We don't want a patient with an A1C of 6.5 or 7% having 4 or 5 times hypoglycemic episodes in a week. And why are we playing these number games, and why are we very worried about the numbers in the A1Cs? This is to reduce the complications, because diabetes is a silent disease and it slowly affects one organ system after the other. The most common ones that we see is the microvascular complications, that is the diabetic retinopathy, where it causes bleeding at the back of the eyes leading to blindness, or it can affect the kidneys, as a result of which the filtration goes down, eventually needing hemodialysis or kidney transplant. And the other thing is the diabetic neuropathy decreases the sensation and eventually causing to have infections requiring again amputations. And other macrovascular complications that we see is either the stroke or the cardiovascular disease or peripheral vascular disease. So what is the connection between the diabetes and the heart disease? So adults with diabetes are up to 2 to 4 times at risk of developing the cardiovascular disease than the patients who do not have diabetes. And the risk is actually more in women than that of the men. In Framingham had study, it actually showed that the cardiovascular risk has doubled in men, whereas it tripled in women with diabetes. And this is a very exciting slide which shows the cardiovascular outcome trial. This has been a very exciting field for endocrinology in the last couple of years. And there are many studies that have come out, but some of them have been shown to have very promising results. And of them, 2 classes of medications. One is the GLP-1 receptor agonist, and the second class is the SGLT2 inhibitors have shown some promising results. So what are the GLP-1 receptor agonists? You must have seen the advertisement like injectable medications like Victoza, Trulicity, Ozempic, Byetta, or Bydureon. These are the GLP-1 receptor agonists. So they mainly act by increasing the GLP or the incretin, as a result of which it suppresses the appetite and slows the gastric emptying, as a result of which patients don't feel like eating much, and also it helps to lose the weight. And it also stimulates the insulin secretion, thereby decreasing the blood glucose. And these medications can be injected once a day, and some can be injected once a week. And the main advantages of these medications are it's going to decrease the cardiovascular risk, it lowers the weight loss, and also decreases the A1C drastically. And these medications are actually contraindicated if patient has any history of pancreatitis or any medullary thyroid cancer or MEN2 syndromes. And the most common side effects that we see with these medications are GI side effects like nausea, vomiting, or sometimes diarrhea. So moving on to the second class, that is the SGLT2 inhibitors. These are the oral medications like Invokana, Jardiance, Farxiga, or Steglatro. They mainly actually act by stopping the reabsorption of the glucose in the body, as a result of which we excrete all the extra glucose out in the urine. And as a result of which it kind of mimics like a water pill that causes some dehydration. So we ask the patients, whoever is taking this medication, to maintain good hydration, drink lots of water in order to avoid dehydration. And this also prevents in having recurrent urinary tract infections, because patients who are taking these medications are at risk of developing yeast or urinary tract infections. And the additional benefit of this class is that recent studies have shown that patients with chronic kidney disease have shown some benefit in the kidney function. And these medications also help in the weight loss and also has cardiovascular benefit. Then coming to the oldest drug, that is the metformin. So there have been many studies before, and metformin did show significant results in the cardiovascular events and also improve the overall mortality. So moving on to the other one, that is according to the ADA, compiling all the data that we have, ADA came up with the new guidelines in 2020. So it shows like once we put the patient on the metformin, the next one is we calculate the ASCVD or the cardiac risk. And if the patient has any history of CAD, that is a coronary artery disease or myocardial infarction or peripheral artery disease, then we are more prone to use the medications like GLP-1 receptor agonists, which are injectables. Or if the patient has any chronic kidney disease or has any underlying heart failure, then we are more inclined to use the SGLT2 inhibitors. So next, moving on to the cholesterol-lowering medications. The first in the list is the statin. So statin therapy reduces the cardiovascular risk by 20 to 30%, regardless of the baseline LDL. And apart from the statin, let's say if you're not able to get the cholesterol to the desired range, we have PCSK9 inhibitors, that is the Repatha and the Praluent. We can use that. And the latest one on the market is the Nexletol, which is a bempedoic acid, which has shown significant results in lowering the LDL. And last but not the least, we have the Visipa, which is nothing but the concentrated fish oil. This medication helps to lower the triglycerides. So what are the ABCs of diabetes? First thing, A, to get the A1C under control. B is getting the blood pressure under control, that is less than 140/90 according to the American Diabetic Association, whereas the American Heart Association recommends it to be less than 130/80. And cholesterol, the bad cholesterol, that is the LDL, we want it less than 70. And please stop smoking. And this is the new technology that we have right now. This is the closed loop insulin pumps. And Medtronic and Tandem, these came up with the closed loop pumps. So here, automatically, let's say the blood sugar is going up, the pump adjusts the insulin rate and it increases the insulin rate all by itself. And once the blood sugar is coming down, it lowers the rate automatically. And if the patient is having a low blood sugar, the pump gets suspended by itself. So coming to the take-home points, we already went through the A1C control, blood pressure, cholesterol, and the smoking cessation. And after we do all that, please concentrate on what we eat and what we do, and talk to your physician and see if you're a candidate for trying any of the newer medications like GLP-1 receptor agonist or SGLT2 inhibitors to decrease the cardiovascular risk. And this is coming to the vaccinations that the diabetic patient needs to take, like influenza, Tdap, zoster, pneumococcal, and Hep B. Make sure that you're up to date with all the vaccinations. And we have the additional resources for the St. Luke's on our website. And thank you. And we'll move on to the next speaker and we'll take the questions at the end of the conference.
Thank you, Dr. Nadella. I'll remind you, please, to submit your questions through the chat box. For this next speaker, I would like to reiterate what Dr. Nadella just shared with us, that cardiovascular disease is the leading cause of death among men and women, and I like to add, all racial and ethnic backgrounds. And most people who die suddenly from heart disease had no previous symptoms. So something as simple as a 15-minute test can really save your life. And with that in mind, I would like to introduce our next speaker, Dr. Vikram Agarwal. He is an expert in multimodality cardiovascular imaging, and as a medical director of the cardiovascular imaging team, he will oversee and interpret cardiac MRI, coronary CT, angiography, and nuclear cardiology, including PET. Dr. Agarwal also has expertise across multiple areas of clinical cardiology and an interest in preventive cardiology. In addition, he's an accomplished researcher who has authored multiple articles in leading medical journals. Dr. Agarwal earned his master in public health at Harvard and received his medical degree at Rural Medical College at Pravara Medical Trust in Loni, India. He completed his internal medicine residency at St. Luke's Roosevelt Hospital, Columbia University College of Physicians and Surgeons in New York, and a fellowship in cardiovascular disease in Mount Sinai, St. Luke's in Mount Sinai Roosevelt Hospital in New York. He also completed an advanced clinical fellowship in non-invasive cardiovascular imaging in Brigham and Women's Hospital and Harvard Medical School. Welcome, Dr. Agarwal, to St. Louis. And St. Louis.
Thank you for the kind words and the introduction. Welcome everyone one more time. The goal of this evening is to create more awareness about diabetes. And my job over here today is to focus a little bit on some of the cardiovascular complications that occur with diabetes mellitus, as have been pointed out by Dr. Nadella so eloquently in a previous talk. So just to reiterate some of the things as to the burden of diabetes that we have, as we know, diabetes is very prevalent. About 1 in 10 person in the US has diabetes. And the important part that is there in this is that although we know that about 1 in 10% has diabetes, about 1 in 4 people do not have the diagnosis of diabetes. So they are walking around with diabetes without knowing that they have it. This is a bit of a busy slide, but I think the thing that I want to point out over here is diabetes does not discriminate between men and women. It affects both the sexes. As can be seen in this slide, the ratio between men and women is almost 50%. The other thing that I wanted to highlight to grow or expand on the fact that diabetes is not well diagnosed, if you look at these numbers over here, if you are between 18 and 44 years of age, about 1 in 3 persons who has diabetes is not diagnosed. When you are between 45 and 65, that number kind of comes down a little bit, which is 1 in 4. And when you are more than 65 years of age, then still about 20%, which means about 1 in 5% are not diagnosed with diabetes. And this sort of represents a significant problem because people can go a long time without being diagnosed with diabetes, as shown by these numbers. Now, everybody knows about the complications or the side effects or how you diagnose with diabetes. What are some of the telltale signs you should be looking out for? Frequent urination, being always hungry, tingling and numbness of the hands or the feet, sudden weight loss, wounds that don't heal, sexual problems in both men and women, and vaginal infections in women. These should be some of the signs or symptoms that you should be looking out for. And if this is something that is concerning, this should prompt a conversation with your healthcare provider. This is a representation of the same slide that Dr. Nadella presented earlier, but I think this is very important because diabetes affects so many different organs that it affects the whole gamut of the body, right from the eyes with the diabetic retinopathy, to the kidneys, to the peripheral nerves with tingling and numbness, patients undergoing amputation because they have bad circulation of their legs, stroke, about 2 to 4-fold increase in stroke that happens in patients with diabetics, and cardiovascular disease, which means that about 80% of the patients who have diabetes will end up dying ultimately of cardiovascular complications. So when we talk about cardiovascular complications, which means it is related to the heart or the blood supply to the body, how does elevated blood sugars or diabetes affect that? So when your blood sugar is high, it leads to increased deposit of fat or cholesterol in the blood vessels. And when that plaque starts building up, it leads to narrowing of the blood vessels. And as the blood vessels start getting narrowed, it reduces the blood flow. And when it reaches a critical juncture, it can lead to heart attacks. The other thing to keep in mind with this is that not only does it affect the blood flow to the heart by reducing the blood flow, high blood pressure is also often accompanied by, high blood sugars are always accompanied by high blood pressure, being overweight or obese, and with high cholesterol. And as we know, all of these are dangerous cocktail mix, which lead to increased incidence of heart disease. So not only is the fact that diabetes causing heart attacks and strokes by itself, but it leads to these other conditions and comes along in a package, which also leads to increased risk of heart disease. Again, to reiterate, because this needs to be reinforced again and again, patients who have diabetes are 2 to 3 times at increased risk of heart disease. About 60% of the patients who have diabetes will end up dying from heart disease. Now, one of the big things that's there is we live in denial, constant denial. And being in St. Louis and in Missouri, I was curious about how frequent, how prevalent is diabetes over here. And when we look at this, this is sort of a heat map of the percentage or the incidence of diabetes across the United States. And as you go from a lighter shade to a darker shade, your incidence of diabetes increases. And as we can see over here for our lovely Missouri, we are not too bad because we are not as dark as probably further down, but we are not even the lighter ones as well. So we are somewhere in between. But this is something that should concern all of us because, as we mentioned, diabetes predisposes you to heart disease, and we in Missouri have some of the worst and the top numbers as far as overall heart disease is concerned, or the chances of heart attacks and strokes is concerned. Over here, as far as heart attacks and strokes are concerned, we are number 1 pretty much in the country amongst the highest numbers around. So the goal of this talk is not to scare you, but to inform you and empower you so that you can make good decisions. So based on the fact that I told you that heart disease is predisposed by diabetes, where it leads to plaque formation, what is important to understand is that this is not something that happens in one day. It is something that happens over years and decades. And again, on the left side of this diagram, you can see this is a normal blood vessel, which is completely clean. And over a period of time, this blood vessel starts depositing cholesterol or plaque. It keeps on getting narrow till the point where it is more than 70% narrow. And that is the time you'll start having symptoms, shortness of breath, chest pain, difficulty exerting. And when you go out to your doctor, usually at that point, they order you for a stress test. And stress test can show changes, which prompts the fact that you may need further testing. But again, to reiterate the fact, the stress test only becomes positive when you have more than 70% stenosis or narrowing of the blood vessel, which means that from the time the blood vessel is clean to the time you have 70% stenosis, a lot of the people can go undetected. And the best analogy to think about this is think about an iceberg. The stress test only becomes positive, which is the tip that is sticking out, but there is more disease that is submerged or underneath that is not being captured. So as somebody who has interest in preventive cardiology, the question that is there is that, can we do any better so that we don't reach this stage when you develop a blockage and you're having trouble to begin with? So we want to talk about what we call as asymptomatic diabetes, which means that you have underlying diabetes, but you are not having any symptoms like chest pain or shortness of breath to state that your heart is at risk. And this is a quick test that has been around for some time now, which is called as a calcium score test. And what a calcium score test is, it's a quick non-contrast CT scan of the chest, which allows us to visualize the blood vessels of the heart to see if there is any calcium building up in the blood vessels. And if there is no calcium building up in the blood vessels, then that's a good sign. If there is calcium building up in the blood vessels, then that is something that needs to have a discussion. So over here, this is an example of a patient who is older, but when you look at the blood vessels of the heart for her, she does not have any disease over here. Now compare and contrast that to this patient. You see all this white stuff inside the blood vessels of the heart? That is all calcium or disease that is building up in the blood vessels. And if you had a choice between the first panel or the second panel, I think most of you should be choosing the first panel. And this is just a comparison in between to reiterate the fact that this is a spectrum where this is an in-between stage where there is some disease, but it has not gotten extensive as the last panel. Now, looking at this calcium score, we are able to come up with scores for this. We give it a number and then we compare it. And the goal of all this exercise is to start you on appropriate therapy if you are a candidate for it, so that we can slow down or prevent the progression of the disease. Dr. Nadella went through an extensive list of medications, and as we get better with treatment of diabetes, we want to pick and choose the patients who will benefit from each medication appropriately. And based on your calcium score, we can actually titrate and figure out how aggressively we want to be treating you, which are the best medicines which may work for you. And this follows sort of a pyramid approach where if you don't have much disease, then the goals are a lot more lenient. And as your calcium score, or you have more calcium in the blood vessels of your heart, then the goals and care becomes a lot more stringent. Now, the thing that's there is that how does it affect us in terms of not only does it affect your care in terms of we can make treatment decisions, but we also know that if you do not have calcium in the blood vessels of your heart, then the chances that you will die of complications associated with diabetes is lower. And this is sort of a good thing if you do not have calcium building up in the blood vessels. So the big take-home point that I want you guys to get out of this is that as far as diabetes is concerned, it is really important that we have tools these days which can empower you to make better decisions. The CT scan that is there is simple and straightforward. It does not require any contrast. It occurs pretty quickly in about 20 to 30 minutes. And by the time the test is completed, it gives you a very good idea about how you should be treating, what are the risk factors you should be focusing on, and your doctors can make a much more informed decision about this whole process. Now, the first thing that I spoke about was if you are asymptomatic, which means if you do not have symptoms. But this slide over here is geared towards patients who are having symptoms, which means that if you are having chest pain, if you are having shortness of breath, what should you be doing? And with regards to this, I just want to point this out first. So when we talk about the blood vessels of the heart, it is really, really important to understand that diabetes does not just affect the big blood vessels of the heart, but diabetes affects these small hair-like structures called as the microvasculature or the small blood vessels. And while we have good technology and method to fix the big blood vessels, the small blood vessels are not so easy to be fixed. The question that is there is that if your small blood vessels start getting affected, we have to treat you very aggressively so that we can maintain your quality of life. About 10, 15 years ago, we did not have good methods to diagnose if your small blood vessels are getting affected. But St. Luke's was one of the first hospitals in the St. Louis region which offered this advanced method of stress testing called as a stress PET testing, which not only tells us if your big blood vessels are at risk, but it also tells us if the small blood vessels are getting affected. Not only is it a better test, but as compared to the usual stress test, which either you or your family members may have had, it is much more accurate. It has more than 90% accuracy as compared to most routine stress tests, which are around the 65 to 70% mark. It occurs as quickly in less than 30 minutes. Radiation is a significant important factor because we have to keep in mind that anytime you have any test done which involves radiation on your chest, and including for the women where it involves the breast tissue, you can absorb a lot of radiation. So it is important to try to choose a test which will decrease your amount of radiation. So this is an ideal test for that. And it gives us a few other nuggets of information to give accurate risk assessment. So at the end, I think it is really important from the cardiovascular perspective to select the right test. So not only can we treat you at an early stage and treat you with appropriate medicines, but even at an advanced stage when you're beginning to have symptoms, then we can address, pick up the disease and fix it as required. Those are the two big take-home points for us from this testing perspective. If you have any questions or concerns, this is my email. This is our office number. Give us a call. Thank you.
Thank you, Dr. Agarwal. Again, for questions, please submit them to the chat box. And we're going to transition into the next topic. And for this, I want to just share a thought with you. Many times when we think about causes of lower limb amputations, we think of war, but diabetes is responsible for more amputations than war. Veterans who survive the horror of war or other dangers of military service often die later from a silent but deadly curse, which is called diabetic foot ulcers. About 40% of those afflicted by this problem die within 5 years. As we get ready to celebrate Veterans Day tomorrow, we will honor all veterans today by learning why foot ulcers are more common in people with diabetes, how to prevent them, and new ways to treat them. I would like to introduce you to our final speaker and the newest addition to the St. Luke's family, Dr. Viktor Ballada. He is a board-certified physician in the Wound Care Center and Hyperbaric Medicine at St. Luke's Hospital. Dr. Ballada earned his medical degree at the University of Vermont College of Medicine, Burlington, Vermont. He completed his medical residency at Bassett Health Center in Cooperstown, New York. Dr. Ballada has been treating patients using standard and advanced wound care since 2009. Advanced therapies include hyperbaric oxygen therapy, bioengineered skin substitutes, negative pressure wound therapy, total contact casting, wood matrix, and collagen dressings. He has been a long-standing member of the Association for Advancement of Wound Care, American College of Hyperbaric Medicine, and Undersea and Hyperbaric Medicine Society. Dr. Ballada joins a large multidisciplinary team to coordinate patients' wound care with experts in podiatry, infectious diseases, dermatology, vascular surgery, plastic surgery, and rheumatology if needed. His goal is to provide compassionate wound care to every patient while respecting their treatment plan choices. And in his spare time, Dr. Ballada likes to jog. He likes to read and spend time with his wife and his 4 children. Please welcome Dr. Ballada.
Thank you very much for allowing me to share my presentation here at this conference. As Dr. Agarwal previously mentioned, he said, I don't want to scare you too much. What I find when I see patients with diabetes in our wound care center and hyperbaric center is that I often try to scare them enough so that they realize how crucial it is for them to follow the recommendations for standard wound care or advanced wound care. So I'd like to talk about prevention of wounds and ulcers, especially diabetic foot ulcers. But there are other wounds that patients with diabetes may suffer from, like pressure sores, pressure ulcers, venous leg ulcers, arterial ulcers, laceration wounds, surgical wounds, thermal wounds, burns, frostbite, chemical burns, cancer lesions. Now, it's hard to keep somebody from getting a surgical wound, but what my goal is it's to point to diabetic patients that surgical wounds may not heal as well as in patients without diabetes. So how to prevent wounds? Pressure relief is important. Diabetic patients should wear proper shoes, and that may start with getting shoes off the shelves that are diabetic shoes with diabetic inserts, but they are not custom made. For patients with feet that suffer from neuropathy, meaning the innervation of the muscles is lacking. The diabetes destroys the nerves that go to the muscles get shriveled, bones shift, and then the diabetic patients needs custom-made inserts in their shoes, in their diabetic shoes. Offloading seat cushions for people who are sedentary or wheelchair bound, repositioning in chair or in bed. Some wheelchairs have ability to recline, tilt and recline. Patients may also use their arms to do chair lifts. And also moisture control. Sweaty skin, skin that has urine on the surface or stool on the surface of the skin will be more prone to developing ulcers and lesions. Swelling is another important aspect of preventing wounds from happening. Swelling also slows down wound healing once the wound is developed. It decreases arterial circulation. All that pressure on the arteries narrows the arteries, and there's less blood flow through the arteries. The key in controlling the swelling in patients with poor arterial flow already, as Dr. Agarwal mentioned, deposits of cholesterol narrow the lumen of the vessel. The key to controlling the swelling is to do it gradually, a little bit of compression at a time. And in time, the arteries will allow more blood to flow into the limb. Infections are more difficult to eradicate when swelling is present. And there's also a study that showed that use of compression garments, compression stockings, has been recommended to prevent recurrent lower extremity cellulitis or skin infection. When the skin gets red, hot, painful, that may be a sign of cellulitis. Treatment of swelling, compression hose, compression wraps that are made from foam with Velcro straps, are also a possibility. The advantage of having a foam wrap with a Velcro strap is that the pressure can be adjusted. When a patient has a compression stocking and the leg swells more, they need to buy another compression stocking. The old stocking is not going to adjust. This is an example of a leg wrap. That one does not include foot, but there are devices that also do include foot in the wrap. Pain. Do not ignore pain. Pain is a gift. We don't know that something is wrong if we don't have pain. Sensory neuropathy causes decrease or loss of sensation. This may be a gradual process in diabetes. And without intact sensation, skin damage may quickly develop. Diabetic patients should every day inspect feet for redness, heat, bogginess, callus formation, and cracks. If a wound or ulcer develops, how should we take care of it? Initial cleansing is important, mild soap and water or hydrogen peroxide. And I would recommend not doing more than couple days of hydrogen peroxide, and to avoid daily cleansing with hydrogen peroxide because of cytotoxicity. Hydrogen peroxide kills bacteria, but cytotoxicity kills cells as well. For daily cleansing, it's better to use wound cleanser or normal saline. Wound cleansers are, for example, of hypochlorous acid, like Vash, Purocin, Microcin, or quarter-strength Dakins. There's plenty of those on the market. No soaking of wounds is preferred in diabetic patients for this reason. The innervation of the feet gradually gets worse and worse, and the nerves that go to the oil glands will cause less and less lubricant on the surface of the skin. The water leaches the little bit of lubricant that's still left, and then the diabetic foot will crack and fissure, and there are entrance opportunities for bacteria to cause infection. Another important aspect of wound healing is to maintain moist wound environment. Goal is not having the wound being too wet or too dry. And changing dressing when saturated. This could be once a day, this could be 3 times a day, depending on the drainage amount. Please avoid leaving the wound open to air and creating a scab. The fastest wound healing is moist wound healing. The scab just is in a way of skin growth. It's not a big thing for young people and children, but as we old, this is more and more difficult. This is an example of dressing that allows for copious drainage, but when the drainage decreases, it does not stick because it's coated with the lubricant. And I would just like to add one thing about the smoking and diabetes. I tell every patient who smokes that after 1 cigarette for 6 hours, the little blood vessels that go to that are around the wound and everywhere in the skin really constrict. It means that they narrow, and blood and oxygen delivery is impaired. And for 6 hours after every cigarette, the cyanides and other toxins in the smoke bathe the wound, so the healing is much, much slower. Thank you very much for inviting me. We will be here for questions at the panel time. Okay.
Panel. Thank you, Dr. Ballada. I'm going to ask the other physicians to join the physician panel, please. Okay. The first question is for Dr. Nadella. When should a person with diabetes consult an endocrinologist? Why not just stick with a PCP or a primary care physician?
So any patient with an A1C of 9 or greater, or any patient who is on multi-dose insulin, like 3 or 4 shots of insulin a day, or any patient who is not able to reach the A1C, the goal A1C, in spite of being using multiple diabetic medications, they would be a good candidate to come see an endocrinologist.
Okay, thank you, Dr. Nadella. Dr. Agarwal, how do I get a calcium score test? And hold on, let me add to that. Does insurance or Medicare cover this type of test?
So to get a calcium score test, since it's what we call as a screening test, we have tried to make it simple for the patients. You do require a prescription from your physician for it, but if for some reason you do not have a physician, or your physician is not ready to recommend this test for you, you can contact us and we can order this test for you. The reason why we insist a physician be involved in ordering this test is so that they can explain the results to you about what it means. The second question is with regards to the insurance. So this is something that insurances have now started covering to a certain extent, but it's not yet available across the board. So at St. Luke's over here, this is an out-of-pocket test where you pay $125 for the whole test and you get the results. So there are going to be future attempts where it will become more streamlined, but for the time being, it is an out-of-pocket test.
Let me ask you, as a diabetes educator, who with diabetes will benefit most from pursuing this type of test?
So I think what the basic recommendations are, if you have multiple cardiac risk factors, including diabetes, or if you are above the age of 45 years, then those would be the big things to make a decision about whether you should undergo this test or not. Without getting too technical, if you are very young in your 20s, 30s, this test is not really recommended because that is too early of an age to start developing the disease which can be picked up on this test. On the other hand, if you are in your 80s and you're already on all the treatment, including the aspirin, statin, multiple blood sugar lowering medications, then the chances that you will get benefit from this test is limited. One quick caveat to this is a screening test, which means that this test is indicated for patients who do not have history of previous heart attacks or stenting or bypass surgery. If you have already had those procedures, this test is not for you.
Okay, thank you, Dr. Agarwal. The next question is for Dr. Ballada. Could you tell us what is hyperbaric oxygen treatment?
Sure. Hyperbaric oxygen therapy includes oxygen under pressure, 100% oxygen being breathed by a patient. The oxygen dissolves in the plasma and then diffuses further into the tissues. The hyperbaric oxygen also promotes growth of new tiny blood vessels. It's called angiogenesis. It kills anaerobic bacteria, and it also mobilizes stem cells from the bone marrow. Those are cells that could become any part of the body, any part of the organ. It could become skin, it could become bone, it could be muscle. So that's kind of in a bullet what it does.
Okay, Thank you. And how would a person get referred to you?
They can either self-refer by calling the wound care and hyperbaric center, or they can go through their physician, and their physician may refer them to us. We usually want primary care physician to be knowledgeable about it.
Would it be safe to say for a person with diabetes is recommended to have at least a visit once with a podiatrist to go over foot care?
Patients with diabetes should see their podiatrists at least once a year, if not twice a year.
Okay.
For issues of bone shifting, sometimes neuropathy, fungal infections of the toenails, and other issues.
So once again, to reiterate how important it is to have a healthcare team when you have diabetes. I have a question here for Dr. Nadella. What special considerations should people with diabetes have during these times of COVID-19?
So patients with diabetes, just like any other patient, has to follow the basic safety precautions for COVID. They need to maintain the social distancing, wear the mask, and most importantly, for diabetic patients, or for that matter, any heart disease patients or kidney patients, we always recommend to get the medications ready in hand. Always make sure the refill and keep them ready so that, they don't need to go and expose them outside in these COVID times. That is very important.
Okay, thank you very much. And I think I have one more question. Is there any more that came through the feed? Dawn? Okay. Hold on, I lost my question for Dr. Okay. Well, since I can't find my question, I am going to remind everybody that there's going to be an email sent out shortly after this event with a resource list of services that we have here at St. Luke's and are also available online and through our region. And before we wrap up, I would like to also mention our winners of today's gift raffle. And if you forgive me, oh, here's my paper. Dawn, I forgot my paper with the winner. Oh, here we go. Sorry about that. We're going to go first. We're going to mention the winner of our massage therapy goes to Barb R. And the gift certificate for a meal delivery from Predikin Foods goes out to Tommy T. These certificates will be emailed to you by me shortly after this event. And also any other questions that have come up through the chat or that come to you after today, please feel free to contact us so we can make those questions reach the docs, and hopefully we can make you navigate our hospital and our services. And I'm going to leave with a quote by Elliot Joslin. He was the first doctor in the United States to specialize in diabetes. And around the mid-20s, he was the first one to advocate teaching patients to care for their own health in an approach now commonly known as diabetes self-management education. And he said something really wise, which I really like and I repeat often, which is the person with diabetes who knows the most is the one that lives the longest. Thank you again for joining us tonight, and we hope that you had a meaningful evening with us. Complete the survey and stay in contact. We appreciate you taking this time tonight. Stay connected and stay well. Good night.
Thank you.